Wonderful. Well, thank you again for all joining. Really excited for this session. Really grateful to have UC Health with us. They've been doing a wonderful job in the team program and have incredibly diligent and focused individuals, you know, really looking at how to optimize this program. So excited for this session. Again, we're going to be fast and furious as we have 30 minutes. Um, just as a quick update, again, welcome to anybody who is new. For those that have not joined before, please feel free to reach out directly, or we will also circulate this deck. But we have a collaborative drive where we have all of this material available to you, including the recordings of today's sessions and the documentation. So please feel free to use that as a resource. Um, We'll be discussing at the very end our June webinar and the summit, additional resources to support you in what you are doing from a CMS team perspective. And also, as we begin moving forward, and we'll talk about this more, the CJRX program that will become live next year that many of us will be focusing on as well. And as another reminder, additional resources, we have been spending the last decade in bundled payment programs through the government. We have resources that you can access through Harvard Business Review, work that we have done, always looking to, optimize on the value-based care that is provided to the patients, all the while making sure that reconciliation is optimized from a financial standpoint. Wanted to quickly introduce and thank once again Danielle Andrade and Melanie Baker. Really excited and appreciate them spending their time with us today. And they're going to walk through the specific initiatives, specifically organizational structure and the work they're doing at UC Health. Numerous hospitals are involved, many physicians, many caregivers, a lot to organize and a lot to manage. And so we're really excited that they're willing to share how they are looking at this, what they are focusing on, the successes that they've already had, and the successes they expect from the groundwork that they're laying at this particular time. So I will go ahead without further ado, pass it over to Melanie and Danielle, and then we'll wrap up at the end after they're finished. Thank you.
Okay, I think if you all can see our screen, then Danny, I will hand it off to you and advance to our next slide. Oh, you're on mute, Danny.
What a way to start. Uh, Again, Danny Andrade, Vice President, Care Continuum Integration for the UC Health System. We wanted to start a little bit in telling you what we are as a system or who we are as a system. We operate in the state of Colorado. We are one of the only, or we are the only local executive team to Colorado hospitals. So we feel really proud about the communities that we serve across our state. We have 15 acute care hospitals. We do on average about 200,000 admissions in inpatient and observation a year, 2.9 million unique patient encounters across our ambulatory and inpatient settings. Have close to 36, almost 37,000 employees right now. So we're really excited about that. And again, it just gives us another way to serve our communities. I think that's it. UC Health right on our. Okay. Melody and I switched this up. She's not feeling well this morning, so I'm taking some of her slides. So forgive me for a little bit of unpreparedness there. But going right into understanding our purpose, care continuum integration is something that's pretty unique in the industry. I report directly to finance, but essentially all care coordination, care management, utilization management, post-acute care, our nurse navigation strategy, all of that reports up through me. So it's unique in that we're able to make decisions really fast that can scale really fast across care coordination across our system and really deliver care quickly to our patients. We truly believe, oh, you can go back, Melanie, and I'll talk a little bit about why I think care continuum is so important. Is really comes down to care coordination being the engine of everything that we do. We say in all of these value-based care programs, if you don't have analytics and you don't have care coordination, you will fail. And those are two really critical infrastructures to being successful. And so we believe that as a system. We think really big in these programs. We like to fail fast. We try things, we pull it back. If we need to, we learn really rapidly. We have short decision cycles in the way that we roll out these things, and we really try to sustain that excellence and gain high reliability across all of our inpatient and outpatient settings. So for governance and alignment for teams specifically, we found out very early on that there was a lot of excitement about this. I know there's quite a few of us that are like, oh, another CMS program, what's going to change? What's going to be new? How long is this going to last? But a lot of excitement in general. And so we had a lot of people popping up in different pockets, whether that was in procedural areas or outpatient areas, and started to ask questions about what are we doing with team and trying to really build their own team specific infrastructure. And so we realized quite quickly that, hey, we have to identify an executive sponsor and we have to have all of these things trickling up to one person so we can say, yes, we're doing that as a system and an organization. We're doing that in our EHR, or we're not making that change, and why. So folks really understood, and we didn't have silos of work happening all over the place. So we quickly stood up an executive sponsor and an executive steer, and then that trickled down into our senior management groups of each hospitals and our procedural areas as well. And then we were able to identify those operators and those service line leaders individually to where we would have to truly operationalize change and manage it at that level. So it was really about finding out at what altitude decisions needed to be made. So if it was a steering decision or something that would impact the system, like an EHR example is a good one, or if it's something that needed to happen really locally or change within a specific clinic, we were able to go to those specific service line leaders pretty quickly. Is this me, Melanie, or are you?
Nope, it's me. I'm just flipping to off mute. So we wanted to highlight just a few specifics. So as Danny said on that strategy point, we're really looking at this as a data shaping year, partnering with Avant-garde. There's no downside risk this year, so focusing on that care redesign, care pathways. I think Danny's going to allude to it again, but we wanted team to really be a catalyst for the care redesign that needs to happen in general. Porter was indicating, right, this is not our first bundled payment model. It will not be the last. This is the way healthcare is moving. So really looking for opportunities to make changes that just make sense for our system. We have an enormous amount of stakeholders. I think I've got over 200 folks on a spreadsheet who have reached out, who want to be involved, or we need them involved. So we've really leaned on a primary team, Microsoft Team channel for posting updates rather than trying to push emails out, along with those meetings that Danny alluded to with engaging our steer, engaging our executives. And then we have an IT strategy. A lot of that is system level work, building out obviously our Epic registry and the beneficiary notification letter process that you all have done as well. And then currently we are working on building out a preoperative report so we can intervene before that anchor stay, expanding our Compass Rose, which is our ambulatory care management workflows, and also incorporating some social drivers of health screening into our pre-op workflows as well. And then, of course, our analytics with Avant-garde. So that is our high-level, quick overview of UC Health and the work we're doing, and we can transition to some time for Q&A.
Wonderful. Thank you, Danny and Melanie. And if anyone has questions, please type those in. We'd be happy to answer those live. But as we go, this is very interesting, and you guys are doing a great job just building the framework so that you have that institutional alignment. So I really want to start there. When you look and get into the details of that organizational structure for the team program. So could you map through and just give us a few more details on, who owns the programs or the program, what committees sit underneath that, how often you're meeting, what decisions are made at each level. I think a lot of people find this somewhat complex when you're managing different service lines over different facilities across the entire system, different stakeholders and leaders. So we'd love to hear how you're attacking that in more detail.
Melanie, I can go ahead and start. Like I said, there was a lot of hesitation, but also a lot of excitement coming from all over the health system. And so when we initially said we have to assign an executive sponsor specific to team that's familiar with team. That ended up being myself, and then we created that executive steer. And that steer was for direction, never tactics. So everything we bring to them is this is the direction that we need to go. Do you agree? Can we execute on a large scale, something in EHR, something like that? We had to move pretty quickly in the beginning. We didn't really start thinking about team, admittedly, until the last quarter of last calendar year. And there were some regulatory pieces that had to come into place pretty quickly by January, like the PCP follow-up and beneficiary letters and things like that. So we had to make some quick direction decisions at our steer. And so once those were stood up, I think that helped a lot in funneling all of those questions that were coming from all over the system. And Melanie alluded to the Microsoft Teams channel. That helped a lot just in transparency. So folks knew, hey, what was going on? What's the most recent update? What are we doing? It's a large system. And to your point, Porter, getting to everyone and the complexities that are involved in that can get to be a lot. So even though we wanted to be really transparent, I feel like there were feelings in the beginning that we weren't transparent, just because it didn't feel like we were doing a lot and being in this team-focused atmosphere. But from the very beginning, UCHealth had said, we're not going to build specific team infrastructure. We're actually not going to build that for any specific value-based care program. We were really intentional to say, this is our catalog of programs. These are all these can't lose care delivery measures, we call them, that if we improve across any of them, they crosswalk to all of these programs. So we wanted to make sure that team could be the catalyst or the things that people were excited about, like the pressure to perform better for all of our patients that we're delivering care to. So I think that was a really intentional decision in the very beginning, that it's not team specific infrastructure, but instead it's how do we enable and create a care delivery platform that serves all of our patients.
No, that's great. I really appreciate that idea. And I think that is the point of the program, right? That it is not just initiatives are not just a subset of the patient population, and that they can be used best practices across all of the care provided. So I think that's great. Danny and Melanie, we have questions from the audience. So if you don't mind, we'll jump there. And I wanted to start with Dr. Ira Kirschenbaum's question because it relates to this exactly. So his question is, how many FTEs are dedicated at the institution to the CMS TEAM program? And then he also asked, what is your total number of CMS cases you are dealing with that these FTEs support?
Go ahead, Mel.
Yeah, I would say we have 0 FTEs that are dedicated. But that goes back to our desire that we're not standing up team initiatives, right? We're standing up initiatives that are going to create success in bundled payment models and value-based care models generally. So, and then forgive me, Porter, can you give me the second part of the question again?
So yeah, and then what's your case volume? So I think the idea is how many people are you focusing in on the program,
Yeah.
looking at that from a case volume perspective.
Yeah, right now we're doing some refinement. I would estimate we have 250 to 300 team patient anchor stays a month, is what we're anticipating right now. I'm sure you all are also waiting on your full episode claims files to see if CMS agrees. And then we're continuing to refine our registry with those as well.
That's helpful. All right, so let me ask you this. Let me do the follow-up. No one's specifically focusing on team. Danny and Melanie, how much of your time is focused on team? You obviously have other things, but of your weekly focus, what does that look like?
Yeah, operationally, I'm the point person for the system. So I would say I have one other very large initiative right now. So it can vary. Probably 40 to 60% of my week is focused on team. I would imagine I am the closest dedicated staff member to team in the system. Danny, I don't know what you would say for yourself.
Yeah, definitely not 40 to 60% of my time because I have a wonderful program director in Melanie. And so grateful for that always. I don't know. I would say it ebbs and flows, right? When we get new claim data or when we had to stand up some standards in the very beginning. It was certainly more time. And then we get to this place of, okay, we're just cruising. We know where our opportunities are and we know where we're making operational changes. And then it's less of my time. But again, it comes back to value-based care is 85% of my time. And so we're constantly managing that entire catalog to ensure that we're, again, delivering that platform of care that our patients want.
That's great. Thank you. Suzanne has a question from the audience, and this is in line with what we're still discussing. So her question is, you have a workforce of 36,000 people. How are you actually defining your baseline level of CMS team understanding to all of your employees? So I think the idea is, how much communication, how much is going on from an educational standpoint to make sure that everyone from administrators to caregivers understand the nuances of the team program, if at all.
Yeah, I mean, that took a little bit of time in the beginning too. We did do a road show. We did explain what it is. We went to all of our senior management groups. We went to operational leaders. We sent a ton of emails with the expectation of, hey, these need to be cascaded to these groups, all of those communication factors. But essentially, the more important thing was to get across, we're not doing anything because of team. Like, we're not going to build it specifically for team. If we're going to work on readmissions, we're working on readmissions because it's the right work to do. I don't care if your patient's involved in team or not. We should manage utilization and we should manage re-encounters. Same for, we use a home first framework, which is every single patient that discharges from our home, we're really asking why not home, and trying to get to that least restrictive, least cost setting, most appropriate setting for the patient at all times. So it's those tactics that we refer to as those can't lose care delivery measures that we're really trying to get people. It's more about a culture than it is understanding what are we doing specifically for any particular value-based care. It's that this is the culture of how we deliver all care. And I think that why is easier to teach than it is specific tactics in any one program.
Yeah. Wonderful. That's great. Thank you. All right, we're going to shift gears. We're going to do rapid fire Q&A because we still have some others that are not on this theme, but interesting questions. So Scott Edelman wants to know if the system, if UCHealth has IRF beds, and how has team affected your ADC?
Yeah, it's a balance. We have 5 inpatient rehab separate and distinct units within our hospitals across our Front Range in Colorado. I would say it has not impacted ADC, but it has gotten people thinking different. And again, that is a culture shift. This can't be heads and beds, right? This is not an ADC fill for volume type of environment anymore. And we as a health system are realizing that we need to shift to use our inpatient rehabs as a value tool. So what is it about our inpatient rehabs that can supply a certain level of medical necessity to a patient that would decrease utilization or excess care outside of receiving that care and services? So it's being real astute and challenging in our multidisciplinary rounds when patients actually do or do not require that level of care. And there's going to be patients in a team episode or any other accountable episode that they do require that level of intensity and high cost therapy services. And that's appropriate too, but it's when you're leveraging it from a medical necessity and a value tool, then people can start thinking about it differently. But initially, I would say that there was some fear and hesitation from our inpatient rehabs that, hey, no one's going to send to us anymore. Well, that's not true. Like, we have a massive healthcare system, and it's about finding the right patients that truly need that level of care, and then again, leveraging it as a value tool.
Great. That's very good answer. Appreciate it. All right, 2 questions, both on the same front. Gain sharing, yes or no? Or any other sort of collaborative agreements with your physicians?
No, for now. I won't say never, but no, for now. We have not engaged in any gain sharing activity.
Reasoning, is that, give us an idea.
We are an academic medical center. I think that does some interesting dynamics and complexity with funds flows there, and have a ton of different physician groups, and it just has not been something that we've been engaged in yet.
Right.
I think we've also just talked through, we would need a lot more robust data. We're so early in the program to justify that kind of conversation.
Yeah. Okay, that's helpful. As a reminder, in our Google Drive, we have some information on gain sharing for those that are interested. Um, Next question from Catherine Johnson. She wants to know about patient optimization, specifically since there are a lot of elective procedures within the team program. So what does that look like? Um, when you're looking at, she specifically asked about clinical aspects, maintaining hemoglobin A1C, BMI reduction. What are you guys doing from a pre-op optimization standpoint?
Absolutely. So this part is being owned in a combination of local and system. Some of our procedures, we have system processes in place. So if we have any one on the call who is an Epic user, right, we're using some care companion functionalities to get patients education beforehand in a very standardized way. Uh, we also have stood up, not for team, but for the benefit of the system in certain areas, clinics that are focused on pre-procedural optimization and really looking at, does this patient need prehab? Is there someone else they need to see before this surgery? So I would say, again, very much owned by those local experts, but also with a system lens to how can we optimize patients and be asking those questions before procedures.
Dr. Rahim has a question as well, and I think it flows nicely with this pre-op optimization, and it's all about risk adjustment. So how and how much are you focusing on risk adjustment capture for the team patients?
I would say we are not focused on risk adjustment capture for team patients. We have a very large ECO. We have about 500,000 attributed lives here in Colorado. And so that capture is so important for how we do all of our work. So again, it's not just for team, but we have a heavy focus. We have work groups with team to tell us, what have we done for HCC capture? What are our changes there? So we're operationally talking about it all the time, but this is not new for us. We've been working on this work far before team.
Okay, that's helpful. The next question, is on the lines of taking the team program and then using it as a structural framework for all of the system and all of the patients. But how do you handle when you have competing priorities for the rest of the patient population? So I'll add, who is the tail wagging the dog or vice versa? What is really driving, these policies? And I think the question, starts to go into like, how does that affect decisions on acute rehab, home care, etc. So really, how do you balance the two groups and how to optimize on both?
Porter, you had me smiling because I think any system, right, there's always multiple initiatives and priorities occurring. I would say Danny in particular has been very focused on making sure we are having the right conversations with our executive leaders to understand where team falls in kind of our system scope of priorities and initiatives. I don't feel like at this point, and Danny, you can chime in, that we've encountered a lot of friction, which is, I think, what you were alluding to with other initiatives. So far, it feels like team is often very complementary to work that is already going on. And it's just a matter of, when standing up project teams, a lot of times I'm finding it works better to integrate myself into a group that is already meeting and working on, right, that clinical optimization or another aspect of care for a particular service line or procedural area, rather than having team being a competing initiative.
Great. No, that's helpful. No, I appreciate that. I mean, that is difficult when you're in a big group and a big system, really deciding what takes precedence. So I appreciate that. We've promised a group that we will end on time. Danny and Melanie really appreciate the presentation and the information. For those that didn't get their questions answered, we will get those answered. we'll put that also in the shared documentation. Any last words, Danny or Melanie? And then we'll turn it over to Jordan.
Appreciate your partnership. Appreciate everyone on the call, and that this is a space where we can all share our different learnings from team and grow together.
Wonderful. Well, thank you both. Um, Melanie, if you'll hand over the screen sharing, we'll wrap up. And thank you both once again. This was great. All right. Jordan, I'll hand it over to you. We're going to go over some of the events that we have coming up and resources that we have available just to make sure that we're supporting everyone as much as possible to have success in the program.
Perfect. Thanks, Porter. So yeah, we have another one of these coming up with UPMC. So obviously we're doing a mountain group right now. We're going to be going a little to the East Coast with UPMC out in June, where they're doing amazing work and able to, again, share some of the great stuff they're doing. We're going to be speaking with their folks in the value-based care side of the house, but should be another great conversation. A lot of great learning for everyone who's involved. And then we also wanted to discuss, I got to share my screen now, sorry. Our summit that is coming up, our Bundled Payment and Care Transformation Summit, happening August 18th and 19th at the Harvard Club in Boston. There is no better time to come to Boston than in August. The weather will be great, and we're going to be having some great speakers. Sasha Wolf, who is, kind of designed the whole TEAM program. Bob Kaplan, Leslie John. So it will be Susanna Galliani. It's going to be a great group. And then we're also going to be doing a Red Sox event as well. Let's scroll down. Yeah, here we are. We'll be going to the Red Sox game as well, which will be fantastic for everyone involved. But again, it's a way for us to bring all these different folks that are working with bundled programs, working with team, and have them have conversations and learn from some of the thought leaders in the industry. So, feel free to sign up right here. We'll, follow up with the link to the website. And again, it's 2 days. Should be a great time and a great learning session for everyone.
Great, thanks, Jordan. And Derek, we'll hand it over to you. This is your 8th summits. Would love some insights from you. You've been at this for quite some time and had a lot of great people participate in these. So thanks for a few additional thoughts.
Yeah, I mean, just building off of what Jordan shared, I mean, we're going to be having tracks related to both bundled payments as well as more broadly care transformation and value improvement. And so the summit will definitely be very useful and relevant to people beyond the team program or beyond the CDRX program to be helping to be driving performance improvement in analytics more broadly inside of your organizations. And really excited to bring people together in person for the event to be able to turbocharge the learning, that you just heard from our colleagues at UCHealth, where there'll be many other health systems who will be sharing their insights, experiences, lessons learned so far with both care transformation and bundled payments. And also be people talking about things that they're still trying to figure out or interested in learning from others as well. So it's going to be very interactive and excited to get everybody together for 2 fantastic days in August.
Wonderful. Thank you, Derek. Thank you all again for participating. Really appreciate it. Any specific questions or anywhere we can be of help and support, please reach out. Danny, Melanie, thank you once again for your presentation and willingness to share your successes and what you're focused on at UCHealth. You're doing a wonderful job. So we'll see everyone in a month and look forward to having UPMC present and learn from their learnings as well. Enjoy the week.